Hi, everybody. Welcome back to Health Law Simplified, where we break down complex health policy issues so you don't have to. I'm Sandy Durkin.
Hi, and I'm Elizabeth. And today we're diving into a fast-changing area in Medicare Advantage, supplemental benefits, and talking about some big updates that are taking effect in 2027. But before we get into it, we're thrilled to welcome our guest, Regan Pennypacker from ATTAC Consulting. Hi, Regan.
Hi, it's so nice to be here. I'm so happy to join you today.
Thanks so much.
We're so happy to have you, Regan. I'm going to share a little bit from your bio. You have, a really interesting background, very different from mine and Elizabeth's, but equally steeped in Medicare Advantage. So we're excited to have you today. So for our guests, Regan Pennypacker is a nationally recognized expert in Medicare Advantage operations, benefit design, and importantly, regulatory compliance. In her current role at ATTAC Consulting, Regan advises MA organizations, state agencies, and healthcare innovators on a vast range of topics, including STARS, member experience, operational strategy, and supplemental benefits, which is relevant to today's conversation. And we knew Regan before she joined ATTAC. Prior to that, she was in senior leadership in MA compliance and quality, where she was widely known for translating CMS policy into practical guidance for plans to implement. We've seen Regan for years on the conference circuit, and we're really excited to have you with us in the studio today.
Thank you so much. This is a great topic, so I'm really glad to be here.
Thank you.
And we're happy to have you.
So, we are going to be talking about supplemental benefits today, and we want to start with sort of a foundation. At a high level, Medicare Advantage supplemental benefits are things, items, services, extras that go beyond what original Medicare covers. And common supplemental benefits are things like dental, vision, hearing aids, transportation, meals, and in-home supports. Historically, CMS limited these benefits to things that were, quote, primarily health related. But over the past decade, they've expanded this quite a bit, both in terms of the kinds of benefits plans can offer and also the types of members that can receive those benefits.
Thanks for the background, Elizabeth. I know that supplemental benefits is a huge part of what distinguishes Medicare Advantage from original Medicare or Med-Sup. These are really valuable benefits, both to plans and to the members. Can you give us an idea of how much of MA plan spending is for supplemental benefits as compared to traditional Medicare benefits?
Yeah, it's not nominal. It's pretty substantial. They're estimated to be about 64 billion in annual spending, or about 17% of total MA payments. So it's a lot.
Regan, having worked inside plans, having consulted with plans, what is your view on these benefits, how central they've become, whether that's been changing in recent years? Just give us the scoop.
I think the costs that Elizabeth outlined, it really talks about that. They have become absolutely central to a plan strategy. When I was working at a health plan, supplemental benefits were probably one of the biggest levers for member experience as well as competitive positioning. The overall satisfaction with these types of benefits left a positive, memorable customer experience. And they've become so prevalent in the industry based on everything I've been seeing. Beneficiaries ask about these particular benefits when they're evaluating their plan options. And so now, as a consultant, I see plans trying to balance innovation with compliance, especially since, as of late, CMS is actively tightening those expectations.
Yeah, and I can speak. I'm a caregiver for a Medicare Advantage member, and she receives through her plan 60 hours a year of in-home caregiving. And she's totally connected with the person that has been coming for a couple years now. She comes every 2 weeks, helps with laundry, helps with, home things, and has really become a companion. and they become friends. So it really can be very meaningful.
For sure. I agree.
That's a wonderful experience. I'm glad that your family member is able to use that benefit. I know
Hmm.
that I had a grandparent who had a similar experience, and she was so surprised to realize that it was included in her Medicare
Yeah,
Advantage plan
it's
coverage.
awesome.
So I want to give a little bit more background on supplemental benefits. There's different categories of supplemental benefits. So, traditional supplemental benefits are those that are primarily health related. But in 2019, CMS expanded the scope of benefits that plans were able to offer to include things that are not primarily health related. Things like, as you referred to, Elizabeth, in-home support services, caregiver support, adult daycare. And then we have a third category, and these are called Special Supplemental Benefits for the Chronically Ill, or SSBCI. These were created under the Bipartisan Budget Act of 2018, and these are distinct because they do not have to be primarily health related. They can't be completely divorced from health. They do still have to have a reasonable expectation of improving or maintaining members' health or function. So you do have to be able to tie it to improvement or maintenance, but it really changed the game for the types of benefits, items, and services that plans were able to make available to beneficiaries.
Sandy, can you give us some examples of things that are eligible for SSBCI, but not primarily health related?
Absolutely. The biggest one is food supports. It is very difficult to provide coverage for food and nutrition under the original Medicare categories. There are some limited ways to do it, but in terms of providing a meal assistance, debit card for food, these are much easier to offer as special supplemental benefits for the chronically ill. Things like transportation to and from healthcare appointments, and then even home modifications, installation of a grab bar in the shower or a wheelchair ramp outside the home, anything that could improve a member's mobility and safety inside the house is potentially able to be offered as a special supplemental benefit for the chronically ill. Regan, I bet you've seen all kinds of things. How have you seen plans operationalize these categories in the real world?
Oh, absolutely. Yes, and I completely agree that the food benefit is probably one of the most prevalent that I've seen, especially with caregivers and beneficiaries hearing a lot of talk about food as medicine. So I think it's just a current theme and something we're not going to see go away anytime soon. It is something that beneficiaries still look for. In terms of SSBCI in particular, this has been an area where plans have explored all different options and angles. Because of that, that's where we've seen a lot of variability. Over the years, plans have taken different approaches to defining eligibility and documenting outcomes. And sometimes it's public and sometimes it hasn't been public. So this is where we're coming to these new rules. SSBCI allow MA plans a lot of similar interventions to those that were available, if you recall, under the value-based insurance design model, which ended this past December. So this is part of the reason that why CMS is stepping in now to add a little bit more structure. Where there may have been some more flexibility under VBID and some of these initiatives were explored, SSBCI is adding a little bit more structure.
Oh,
Hmm.
that's good context. Thank you.
Yeah, very good.
And thank you for giving a little preview into CMS tightening the rules for SSBCI. So we're going to turn to the 2027 final rule. A lot more regulation in this rule than, we might have expected when, the administration first came in and indicated that they had more of a deregulatory agenda. And there is a good bit of deregulation in this rule, but there is also a lot of new rules, and special supplemental benefits for the chronically ill is one where CMS is tightening the reins. One big change is that CMS has revised the regulations to make clear that in order to be eligible for SSBCI, a member has to meet this very technical definition of being a chronically ill enrollee. It's not enough to just have a chronic illness. It's not enough to
Hmm.
just have diabetes or COPD or any other, serious chronic condition. There's actually 3 specific criteria in the statute. The first of which is that you have to have a medically complex chronic condition. But in addition to that, CMS is requiring plans to show that a member also has a high risk of hospitalization or another type of adverse health outcome. And third, a need for intensive care coordination. So going forward, MA plans need to show that a member meets all 3 of these elements to qualify as a chronically ill enrollee in order to even be eligible for a special supplemental benefit for the chronically ill. And then CMS has also said that plans need to rely on objective evidence to demonstrate the enrollees meet this requirement. It's not enough to allow an enrollee to just check a box and say, I have a chronic illness and I need intensive care coordination. So it really struck me in reviewing this rule that CMS calls this a technical shift. It says this has always been the rule. It's in the statute. I don't know that it's that simple and clear cut in practice. And I was hoping, Regan, you could give some insight into, do you think this is a shift from where plans have been operating from historically? What's your perspective?
It is pretty meaningful of a shift, especially since there has been that much variability in the past. Many plans and supplemental benefit providers, they had built processes that were pretty flexible and less standardized to different degrees. So moving to a new fully objective and auditable criteria across all 3 of these elements, this is going to require a lot more integration and coordination across a number of different areas, including the clinical operations, analytics, as well as compliance teams. It's likely going to be challenging, Sandy, in the first part of the year, since in my experience, most plans wish to verify that beneficiary eligibility for that benefit as soon as possible. So usually that's right at the start of the year. So foot on the gas, it's going to be really important to get it right as soon as possible.
That's a really great point. CMS talked about in the final rule that a lot of plans had a practice of having a grace period or like a pre-verification period where they would provide coverage for the special supplemental benefit while the plan did the behind the scenes work to validate that all the criteria were met. And in this final rule, CMS said, no, 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 you have to establish eligibility before we spend a dime on supplemental benefits for the chronically ill. They did say you can go ahead and verify eligibility as part of the enrollment process. You can do that before coverage even starts. But to your point, that means foot on the gas.
Yeah, aren't there some instances where you can look back at things like recent hospitalizations? There might be claims data in some cases that would validate this.
Exactly. Claims data, health risk assessments, these are the types of objective criteria that CMS wants plans to be using to validate.
Yeah. And I thought there was some good insight in the preamble to the final rule where they're saying you can't just self-attest that you're eligible, but you can self-attest certain facts that are used to determine your eligibility. So you could use a survey or, something like that if it's, I have trouble walking or, things like that that would feed into the clinical determination of the high risk of hospitalization or other bad outcomes.
That's a really good point. And, it might sound obvious. You can't have members self-attest, but it seems like plans have been doing that to
Hmm.
a
Yeah.
certain extent. And yeah, the distinction you draw there is meaningful. They can't self-attest to eligibility, but they can self-attest to having, these various social determinant of health factors or other factors that would inform the analysis. So the second part of the big SSBCI change is a new transparency requirement. So all those objective criteria that the plans need to have to determine that a member is chronically ill in the first instance, and then that they qualify for a specific benefit, say a grab bar or a wheelchair ramp or food assistance. Those objective criteria need to be published on plans member facing websites. So this is not totally new. Plans were already supposed to have written policies for eligibility. These should be in place, but again, caveat, they might not have been in place for all three elements of that definition. So there might still be some work to do to figure out what the objective criteria are. But the requirement to post it on a website, that's brand new. And it is I think, a really important step for helping beneficiaries understand what they're actually eligible for before they enroll and then even after they enroll, because we all know sometimes members enroll based on advertising for these supplemental benefits, and then they don't actually, that doesn't actually translate to receipt of the benefits. So Regan, I wanted to get your take from an operational standpoint. What challenges do you see facing plans in trying to implement or comply with these new transparency requirements?
Sure. The transparency, I think, was probably a long time coming, especially since it does help, like you said, beneficiaries understand their choices and their criteria for eligibility. Even though there was, if you recall in the final rule, there was some pushback, some industry pushback about the criteria being proprietary. I think the agency really thought it was in the beneficiary's best interest to be fully informed to see if they do qualify, because that can inform their plan choice, which ties them in for that contract year typically. So
Hmm.
one of the biggest challenges of implementing this benefit is going to be translating those complex internal decision points into something that's not only streamlined for operations, right? The intake of the information to the evaluation to the determination for eligibility, and making sure that it's accurate and member friendly, that it's clearly communicated. Plans have to align between compliance, marketing, as well as their digital or web teams to get this right. As you mentioned earlier, Sandy, both the criteria for the chronic illness verification and whether they qualify for the benefit need to be posted for the coming benefit year. And from what I've seen in my research, a few plans have already posted their criteria for SSBCI. It is just a few, at least the ones I've
Good
checked.
for them.
So web teams need to be included in the planning if they're not already. Also in the rule, which was interesting, CMS noted some plans have neglected to include the eligibility criteria in the evidence of coverage, or the EOC. So it's also going to be important to ensure that the detail is in the EOC and make sure that that is in alignment with what is posted on the member-facing website.
It also seems like this isn't specifically required, but as plans are putting together their agent and salespeople training, this seems like an important piece to highlight when they're helping people navigate their choices, to understand what these things are, what's available. If they've heard about a friend or a neighbor getting something, would they be eligible for the same thing? Because you can tell, to both of your points, CMS does seem to be concerned that people are making choices based on things they hear, and then they end up enrolling and they can't get the benefit.
That's a great point, and I'm glad you brought that up because those benefit conversations start happening during AEP. And so this isn't a 1-1 goalpost. It is, a 10-1 or earlier. The planning should be happening now to prepare for those agent and broker conversations to make sure they're fully equipped with the information to have those conversations.
Yeah. Yeah.
I'm envisioning fights between legal teams that want to have every single disclaimer and marketing teams who are like, we need to make this member friendly. It's going to require all hands on deck.
Yeah, for sure.
Definitely.
Another big topic in this 2027 final rule was debit cards in the supplemental benefits context. CMS added a good bit of detail, and they start out their discussion of debit cards by emphasizing that debit cards are not a supplemental benefit. They are simply a delivery mechanism that a plan can use to, offer certain substantive supplemental benefits.
That's a really interesting distinction. And I don't know that that's how members think about it, right?
Right.
They want the debit card. And my understanding is that CMS put in some pretty tight guardrails for plans
Yeah.
that do choose to use debit cards as a delivery mechanism. What are some of those guardrails?
For one thing, the cards have to be electronically configured to function in real time so that they only pay for approved items. And not to get us off track, but there are very specific lists of approved items and things that cannot be covered, especially under a over-the-counter benefit. So they have to work in real time, only pay for things that are approved. They also have to provide customer service support so that if somebody's at the counter trying to check out with their debit card and things are not available, they have somebody to call or some way to get customer support. The plan also has to provide an alternate way to get reimbursed if the card doesn't work at the point of sale, or in some instances, if the person has out of network benefits. And we'll get to that in a second because that's another big development in this rule. And also, the debit card has to be limited to a single plan year. So the value of the debit card can't roll over to another year. But there was a big emphasis on out-of-network access for supplemental benefits, which I think will be new for some plans, even though it was couched in terms of, well, this has always been the case. My understanding is that hasn't always been the case for PPOs in particular. So, Regan, where do you think some of the challenges will come up for plans with that out-of-network expectation?
Yeah, great question. Because we are hearing currently so many questions about this aspect of the rule. Because many supplemental benefits that you mentioned, including things like vision hardware, they're administered via a debit card. The debit card is not the benefit. The vision hardware is the benefit. Delegation oversight is going to be a primary focus. Plan sponsors have to ensure that their business partner's platform, that what it does in practice actually matches CMS's expectations that you listed earlier, especially around the real-time controls and out-of-network reimbursement. I think we've taken for granted that these debit cards are magic and that our business partner automatically programs them to include only the covered benefits and to approve them seamlessly. But I believe CMS, as well as plans, have heard some complaints or concerns when that didn't always happen, sometimes through user error, but sometimes through no fault of the user, through something system generated. So this is going to be something that PPO plans in particular, though they may not be able to adjudicate an out-of-network benefit in real time, they will have to make sure, like you mentioned, there is an alternate reimbursement method.
Yeah. And I'll just add, this is a little off the topic of debit cards, but they have emphasized in this rule and then also in some of the bid guidance that they have that out-of-network expectation for PPO plans for all supplemental benefits. So that's going to throw a wrench into things, especially for situations where benefits are delivered through like a PMPM contract with a vendor with its own network, and it's not fee for service. And then what do you do if somebody goes out of network for a hearing aid and you're paying a vendor PMPM? Anyway, a lot of challenges raised here.
And better to start thinking these issues through early before you have a member
Absolutely.
trying to get their hearing aid out of network. You want to be prepared.
Absolutely.
And absolutely,
Yeah.
this is, your points about vendor oversight, Regan, are so important. I think that's a great example of a vendor relationship where you want to have legal or compliance asking the right questions before the engagement even begins, to make sure that they're prepared to comply with all of these new requirements.
100% agree. To use a dated Broadway reference, I think compliance will want to be in the room where it happens and be listening to these benefit providers who have their own compliance teams and more than likely have evaluated this rule and have their own ideas on how to comply. So it should be very interesting.
Yeah. Yeah. And then it'll also be important to think about who has the onus to comply. How is your contract structured? Is it structured today so that it would require providing something like out of network if that is the current interpretation? Or do you need to amend it? Or do you need to think about how it's your, but a lot of implementation analysis will need to be happening right now if it hasn't started already.
Definitely.
And we always welcome a Hamilton reference. It's never too late.
Yeah, I don't think that's dated. I thought you were going to do like, I
Some
don't
Andrew
know,
Lloyd Webber.
Oh,
South
yeah.
Pacific or something. That's dated. Hamilton is
Well,
not.
I think I saw a note that it's at least 10 years old now.
Yeah,
So
we're
I
old.
love
That's
that.
not
I
dated.
think that's great.
That's not dated.
Yeah.
All right, Elizabeth, tell us about over-the-counter benefits.
Yeah. So CMS has gotten really granular about what is allowed in their interpretation, and it is, I will say, it is not all. It's clear. They have a list. It's a non-exhaustive list of things that are okay to have in your over-the-counter benefit, things that are not. I will tell you, don't rely on your intuition, because like supplements, they actually name, garlic oil and certain kind of very specific supplements that are fine. Breath treatments, mouthwash is not. Body wash, shampoo is not allowable. And so I'm guessing there are vendors and plans that are going to need to reconfigure their lists of approved items based on those lists, which, to my knowledge, Regan, correct me if I'm wrong, but those lists are only in the preamble to this 2027 rule. I haven't seen them anywhere else.
Nowhere else, to my knowledge, they have not been published anywhere. So I've
Yeah.
been reinforcing to everyone to pull those lists out and make sure you document them for now.
Pull those lists out of the preamble to this final rule. So permissible things are like analgesics, blood pressure monitors, first aid supplies, vitamins. I said supplements, and the list goes on and on. That's just a selection. Things that are not allowable: air conditioners, cleaning supplies, cosmetics. They seem to be distinguishing like hygiene from, well, that could be an overgeneralization, but things that I would have expected to be coverable are not. But some of the things that can't be just a general over-the-counter benefit for all of your members might be allowable under the SSBCI as special supplemental benefits for the chronically ill that we talked about earlier, depending on the context and the person's eligibility. So that's an important thing. If you are relying on over-the-counter for your chronically ill folks to get certain things, you might want to think about doing that through an SSBCI. So, Regan, how are you seeing plans implement this new guidance and interpretation of the OTC benefits?
Yeah, first of all, Elizabeth, I love that CMS provided a list of covered and non-covered items in the preamble. Where there is ambiguity, I see plans being a lot more deliberate where they need to document clinical rationale and linkage to outcomes to include it as a covered benefit. I liken it to, when I was thinking about this, the IRS's list of qualified medical expenses that are includable and not includable
Mm-hmm.
for a health savings account reimbursement. I have an HSA, so those lists are not comprehensive either.
Mm-mm.
And so it's important that anyone using their HSA have backup, such as a prescription or a doctor's note, in the case they become audited. So I think in a similar fashion, what may have in the past been more designed more on intuition based decisions for some plans will have to be, if they weren't already, much more evidence and compliance driven.
Interesting. Yeah. So we should talk about operations. Like what should people be doing right now?
Well, the bids are in, as of as of our chat right now, they are in, and so, those decisions have been made in terms of
Mm-hmm.
what they have asked CMS that they would like to cover and offer for 2027, so those conversations with those benefit providers, should be happening, and I
Yeah.
envision that if there is a particular benefit that wasn't listed necessarily, perhaps they have already discussed it if they wanted to raise it with CMS to see,
Mm-hmm.
is this something that, in your judgment, would be allowed? And in my experience, there's a way to explain to CMS why they want to put something in the bid. CMS could have said, put it in the bid, we'll evaluate it there. So a lot remains to be seen.
Mm-hmm. Thinking about operational readiness, some other thoughts that come to mind are, putting together those criteria disclosures for the SSBCI. And, once you settle with your vendors, especially your debit card vendors with the new requirements, actually require testing and really validate that they're going to be able to administer those in a compliant way. And then make sure all your lists out there of the over the counter items that are eligible are up to date and consistent with the new guidance.
Absolutely. Think about all the audiences that need information for these changes. Your customer service representatives need to know how to react to a request for the benefit.
Mhm.
Sales needs to be able to communicate clearly with beneficiaries considering joining the plan that the
Mhm.
information is accurate and how they can qualify, and those responsible for evaluating and making that objective decision need their own information. And then how do you translate that into implementation and making
Yeah.
sure the member gets that benefit? So the variability of the audiences that need a little bit of care and feeding is
Mhm.
pretty wide.
Yeah. And probably, yeah, I'm thinking you mentioned customer service, like talking points to think about, okay, what are people using that might be going away? This is just a general beginning of the year question. And how do you prepare customer service to explain the changes and what rationale you want to offer for those changes?
That's a great point. They have a great opportunity to retain their membership if they have a good pathway to explaining what is coming for the next
Hmm.
year and how it can also continue to meet the beneficiary's needs.
Yeah. Yeah. So, yeah, just kind of thinking broadly about supplemental benefits, we know they're important to members. They're a big factor in plan selection. They can be valuable to plans in addressing social risk factors in their population, and they have the potential to reduce avoidable utilization. So, thinking about for example, the in-home caregivers for people at risk for hospitalization could really be cost effective. Um, I hear there's some question on some of the things, how much they are improving health outcomes. It might be sort of lack of data more than, a certainty that they are not. But I think that it's going to be really vital to evaluate those outcomes and evaluate how important these things are to the beneficiaries. But CMS clearly wants these things to be used in a targeted, evidence based way and that they be consistently applied. So do you have any kind of final thoughts, big picture, Regan?
Consistency is key, just like you said, with the agency trying to strike the right balance. They want to preserve the flexibility for plans to innovate and to compete in the market. And ensuring accountability for that is going to be really important. I see compliance teams prioritizing increased monitoring and auditing because of the increase to inherent risk because of these
Mm-hmm.
changes. So I see early monitoring and auditing to test that implementation. And if you have seen on the OIG's work plan, OIG is currently targeting compliance with federal requirements by reviewing selected Medicare Advantage organizations on OTC to determine whether those OTC benefits are accurately reported and administered. So I don't anticipate this is going to be the last OIG audit of this type because of
Mm-hmm.
the sensitivity around appropriate spending.
Yeah,
So this is going to
agree.
be an interesting topic to watch.
Yeah, it definitely wasn't talk about fraud in this context as I read the preamble. It wasn't a focus, but you can see how this dovetails with the concerns about, just making sure that federal dollars are being used appropriately.
Absolutely. Well, thank you so much for joining us, Regan. It was a really great discussion. And, we've heard that with the pressure on plan margins, there may be a bit of a still decreased emphasis on supplemental benefits, but they're certainly not going away. And, there is a lot for plans to be doing right now to get ready for 2027. So thank you so much for sharing your insight.
I was so happy to join you both. This is a great topic, and I know a lot of your audience members are going to be interested in it. So I look forward to more conversations.
Thanks, Regan. And thanks to all of you for listening. If you enjoyed this episode, be sure to subscribe and share Health Law Simplified.
Thanks. We'll see you later.
Thanks, everyone.
Bye. If you want to find out more, go to strategichealthlaw.com. This podcast is for informational purposes only and should not be considered legal advice. If you need legal advice on any topic we've covered, please consult an attorney with appropriate experience in health law. Our music is Galaxy Love by Johnny Duke. Until next time, thank you for listening to Health Law Simplified.